Let's talk a little bit about risk assessment. All right, so when I'm talking about risk assessment, what do I mean? Risk assessments can be broken down into many different subcategories of assessment. I'm breaking them down between violence risk and sex offender risk assessments here today. Both of these could be whole classes. I'm giving you a snippet. If you like either of these, if you like what you're hearing, go seek out specialized training in both or either of these. But violence risk assessment, you could be talking about violence risk for a violent offender, domestic violence, child abuse, workplace violence. There's many different areas. If you're interested in doing workplace violence assessments, then I suggest seeking out Mr. Kaywood, who is one of the leading experts in workplace violence assessments. He's actually called into workplaces all over the U.S. He's worked with the Department of Defense. He's worked with all types of people. He's been a guest speaker. He's super nice, and he's currently working toward his PhD. His website, I believe, is factor1.com, F-A-C-T-O-R-O-N-E. And he wrote this book. I don't think I got him to sign this one particularly. Go this way. So that's one of them. Sex offender risk can be broken down into juvenile sex offenders, adult sex offenders, female sex offenders, male sex offenders, and further broken down into use of pornography, rape, and child molestation. For my internship, it was a forensic internship, and I worked with all of these groups. I worked with the female sex offenders, the adult sex offenders, and juvenile sex offenders. Although I didn't work with juvenile female sex offenders, only juvenile males. And it is interesting work, and doing the evaluations is interesting. But for any type of risk assessment, you're going to be trying to identify different variables, specifically risk factors, protective factors, and treatment factors. And risk is really, any kind of risk assessment is really looking at different levels of dangerousness. And you know, they can be broken down into severe dangerousness, mild dangerousness, but all of the tests really do help us to try and predict that level of dangerousness, but not so much that as being caught again. Are they going to be caught being dangerous? It's designed for looking at reoffending and recidivism. So we can't actually say with any degree of certainty, yes, Dr. Prine is going to go out and punch someone today. We know that he's been punching people. He likes to punch people. But we can't predict that today we know for certain he's going to be going out and punching people. But we can say that there's a degree of certainty, there's a likelihood, there's a chance that he might. So the rationale for risk assessment is identification and intervention, and prevention, if nothing else, but not necessarily prediction as much as we say it's for prediction. We're really trying to prevent it. That's the whole point to a risk assessment, is prevention. So the concept of need-risk responsivity was first put out there, I believe, by Anders in 1990. And risk is really those most likely to reoffend should receive the most treatment and intervention. That's what the theory behind risk is. Need is the importance of identifying deficits associated with offending risk, and responsivity is the likelihood of responding to interventions designed to reduce risk. So this model has been adopted by a lot of different people who are doing violence risk assessments and any kind of risk. So the key concepts for risk assessments are dynamic risk factors and static risk factors. And dynamic risk factors really are the ability or the capacity to change over time. For example, something like sobriety. Right? Whereas a static risk factor is focused on historical risk, historical factors, and things that don't necessarily change over time. So to solidify this type of idea, I want you guys to tell me some static or dynamic risk factors for heart disease. What do we know is a static risk factor, something that's not going to change for heart disease? That's definitely first and foremost. If there's a family history of heart disease, that's never going to change. What else could be a static risk factor? Sex. Gender? All right, gender's not going to change. That's also a static. What are some of the dynamic risk factors? Things that can change over time for heart disease. For having children, they cause stress. That would go under a stress subcategory. When they grow up, it goes away. All right, so you guys are able to easily identify static and dynamic risk factors for heart disease. That's something that we've all been kind of taught, hopefully, or have heard in commercials for the drug reps or whatnot. So we all kind of know. We all know if we exercise, eat right, keep our blood pressure down, minimize the stress, we can do something to help combat heart disease. Can't really do anything about our family or our gender. That's not going to change. But we can do some things that can. Let's talk about violence risk. What kind of dynamic factors do you think could go into violence risk? That's things that could change over time that will contribute to someone becoming violent. Where they live, okay, environment, inner city gangs, that sort of thing, good?
Yeah.
So marital stress or, marriage at all. Provocation, sure.
Personal.
So people, places, and things. You might be able to change your SES. That might contribute to violence, maybe. All right, what are some static risk factors that can't change from the history? Genetics. So when we're talking about risk, violent sex offender risk, keep these variables in mind. These are the things that we can change, and these are the things that we can help people cope with or learn from. They can never change their history of arrests, but we might be able to work toward preventing new arrests. And that's the whole point behind risk assessment, is prevention. So for violence risk, there are many, many tools out there for helping with violence risk. The FBI statistics say that over 1.3 million severe violent crimes are reported in the United States annually. This taken straight from their website last night. It's estimated to include over 11 million Americans experience at least one violent act of victimization a year. Prevention is better than to intervene, so that's the whole point of this. And it was very interesting. I had pneumonia, first time in my life, a couple months ago. And I went into Kaiser because I was coughing and someone suggested I might want to go. And Kaiser actually asked me a whole questionnaire on, are you currently living with someone who's violent? Are you currently dealing with a situation that you'd rather get out of? Have you and your spouse been violent toward each other? It was like about 6 questions that was doing a violence risk assessment for victimization concerns. I thought that was phenomenal. It was fantastic. And the lady was a little apologetic. She's like, I'm sorry, we have to ask this from everyone now. And I'm like, no, catch it. That's good. That's, getting some prevention in there. And so the movement is toward trying to catch things before they happen on every front. So I thought that was kind of interesting that they're doing that there.
No correlation with pneumonia.
No correlation with pneumonia, but they ask everyone who comes in the door just to kind of catch it, to try and catch it. So there's many types of evaluation. Way back in the day, it was all based on just clinical judgment. And there are some people out there that still do risk assessment just per clinical judgment. However, they're getting dinged in court because it's best to have some sort of measure in there to help the clinician become objective, to help structure the interview, and to help base what you're getting on norms. So I'm just going to briefly touch on some of the risk assessments that are out there. The VRAG is an actuarial measure based on only static factors. It's found in that book, the tab section in the back has the scoring for it. That's a Violent Offender Appraisal and Managing Risk book, and it's on my recommended reading list at the end. The purpose of the VRAG is really to predict any long-term violence risk individuals with prior violent episodes. The VRAG, the SORAG, there's a lot of different, the HCR20, all of these look at the HARE scores. The HARE, the PCLR, which is the psychopathy checklist, aka the HARE, informs HCR20, VRAG, and a couple of others. It requires specialized training. So if you want to administer this, you have to take, I want to say it's a 16-hour course. I know I went to it a few years ago. And then after you've taken the class, they recommend strongly that you have between, I think it's 5 and 10 inter-rater reliability scores with this, so that you and at least one other person, if not several other people, both score the same either vignette, records, or actually administer it and both score it together to get your inter-rater reliability up. And I did that with a colleague of mine, and we were batting 100 almost every time, at least 90 to 100 each time. So it's based on 20 items, and it does have a specific cutoff for psychopathy. And what is psychopathy? Oh, what I'm passing around here is 2 copies, actually. I'll pass around one here and one here. One of these is the structured interview form. You don't actually have to use this. You can use just a clinical interview that hits on a number of these, but this really informs your scoring. So it's recommended that you use this or something like this to inform your scoring. It is based not only on the clinical interview, but records, and some people don't even do a clinical interview, they just look at records, because if you have someone who's refusing to do the interview, then you can do it for records. But what's psychopathy? Lack of conscience. Okay. Lack of empathy, lack of consciousness. HARE defines psychopathy as a constellation of affective, interpersonal, and behavioral characteristics, including egocentricity, impulsivity, irresponsibility, shallow emotion, lack of empathy, guilt or remorse, lying, manipulativeness, and persistent violation of social norms and expectations. All of that is in the HARE, and all of those feed into the different scales of the HARE. I don't have permissions to get into those or actually teach you how to do the HARE, nor would I, because that's a 16-hour course and beyond the scope of this CE. But if you want to be using this measure, just go ahead and pass it on. I highly recommend that you go out and seek out the training. I believe it's Specialized Training Incorporated. Does the training on the HARE. They do it, I want to say, twice a year. If you email me, I'll email you their website, because I've got it bookmarked at home. And you can go on their mailing list and go to one of their trainings and get certified to do the HARE. And it does, as I said, inform the HCR20 and the VRAG. The VRAG was normed on mentally disordered offenders, MDOs. So it is one of the best measures that's touted as one of the best measures out there for MDO. Do you use that? So getting to the HCR20 is a 20-item-based form that's based on historical, clinical, and risk management factors. It's based on both static and dynamic factors, making it a stronger measure for the violence risk assessment and violence prediction. The manual provides definitions and guidelines for each variable, and research shows that it's got really good predictive and post-predictive accuracy that parallels the VRAG and Static 99 for both correctional and civil places. So it's a good thing to use for correctional and civil, for everyone, in essence. So you don't just use it on correctional setting. Some of these are normed for correctional settings only. The PCLR informs the VRAG and the HCR20. The PCLR, otherwise known as the HARE, is the psychopathy checklist. It looks at factors that go into psychopathy, and the rating that you get from there can inform your violence risk prediction. All right, so there are many other tools that are out there. Of course, the HCR is the one that's being used the most, but there are other tests like the SARA, which is the Spousal Assault Risk Assessment Tool. It looks at spousal assault history, criminal history, alleged and most recent offense history, and psychosocial judgment. And it has a quality control checklist that determines the extent to which a professional has assessed risk factors of importance, and it looks at clinical empirical literature. It also has 20 items, and it looks at if there's a posed threat to spouse, children, or other family members involved. I don't have a copy of this. I've actually never seen this, but it is one of the tools that are out there. The RAGE V is the Risk Assessment Guideline Elements for Violence. It's put out by the Association of Threat Assessment Professionals, and it's really approach to assist individuals and organizations in considering factors to provide a thorough evaluation to help create opinions regarding potential risk and future violence risk. I actually do have a copy of this that was provided by Mr. Kaywood, but I did not have permissions to share it, so I did not. And I believe it is more used for organizational and workplace risk factors. And then, of course, the SAVRI, the Structured Assessment of Violence Risk in Youth, is normed for youth. And then we talked about the PCLR. So when doing clinical interview for violence risk, you're going to be looking at a number of different factors. You're going to want to do your regular clinical interview, but you also want to look at and focus on things like a history of child abuse, family of origin dynamics, current job stressors and length of employment. That goes into stability. Other stressors in the house or home, stability factors. What sort of things are keeping this person stable? Do they have friends? Do they have a support system? Do they have hobbies? What are their things that they do in their fun time? What sort of things do they do to unwind? And of course, you want to do a full mental status exam. But what's the best predictor of future violence? That's right, past violence. So when doing a risk evaluation, you definitely want to look at any history of violence, including every single past history of violence that they were caught for, incarcerated, and arrested. And I know you guys all know this, but the difference between being arrested and convicted is large. So if you just say, how many times have you been convicted? They might say, none, I've never been convicted. Or I was convicted once. The next question that should follow up was, how many times have you been arrested and what for? Oh yeah, I've been arrested 16 times. For what? For bar fights, for fighting with my girlfriend or wife. But they always let me out. They always, dismiss it. That's important because it can help you figure out prediction for future violence. You also want to know about ideation, fantasy, intent, and plan. Are they planning? Are they sitting around ruminating and they've got a plan to go and conduct some sort of violence? Possibly, most importantly, do they have access to a weapon? One of the vignettes that I used to use for one of my finals went through a long discussion with a 16-year-old girl who said that she's going to get C4 and go blow up her high school. She hated her high school. She got expelled recently. She hated her teacher, and she was going to go blow up the high school, and she was going to kill everyone in it. Well, one of the questions that follows is, do you have access to that C4, or is it a fantasy? And so that, in addition to a whole bunch of other things that we looked at, brought the risk level down considerably because of no access to the weapon, until someone pointed out, one of my smart students said, you can probably get C4 online if you really look hard enough. And I was like, oh, yeah, okay. You also want to look at labile affect and agitation, substance abuse, impulsivity, How impulsive is this person? And possibly one of the more important things is, do they have a target? Do they have someone in mind that they want to get even with or get back at? The history of violent acts is important to get into all of those details of those violence acts. One of our audience members just challenged the best predictor of future violence is past violence, and quoted the Scott Peterson, because oftentimes you will have someone who's convicted on only one count with only one instance that we know of violence. And so on all measures, they will show up as having very low violence. So even though that's something that we keep in mind as evaluators, that's nothing we would ever say on the stand or admit to in public, because that's not always accurate, though it can be considered in part accurate for some cases. And you know, the fact is that prediction is a horrible word. Prevention is what we're looking for. So if you're on the stand and you're asked that question, well, doctor, what's the best predictor of future violence? You can just talk about, you know, what we're really looking for is prevention and preventing future violence. No, we never say he will or he won't. We never say with absolute certainty. We say that there's probability. We use the scales that our objective measures allow, and that's the best that we can do. Even though we might think 100%, we wouldn't actually write that. That's the best that we can do. And build in those preventative things. Identify the interventions. That will ultimately be the best thing for the jury or for, you know, the parole board, is to really figure out what can be done to prevent that. And we come back to these dynamic risk factors. In your evaluations, you will identify all of those factors that may go into him being violent again. And that's when you say, okay, if we can build in a support system, if we can build in a healthy, stable environment, if we can build in a job and a schedule, it will help him lower his stress level. And he's had now 20 years of therapy and built-in coping skills, so he is at lower risk for reoffense. Moving on. All right, so the history of violent acts, it's important to get all of the details, instances, arrests and convictions, as I said, and perceived loss of control. This is important, this perceived loss of control, only because, and it's kind of interesting, some of the research that's being pulled out on gang activity. And inner city, when you were talking about the environment, inner city, or the what did you say, the barrio? The barrio. Because oftentimes violence is cultural, and it's culturally supported, and it's culturally appropriate. And it's not, you know, you feel disrespected, you get into it with someone else. It's not a loss of control, and it's not necessarily psychopathic, but it's something that you do to save face. And once the fight is over, you're friends again, you know, you're top dog or whatnot, and you go on. And it's not necessarily something that would feed into a loss of control and getting into fights. So when you are doing a violence risk assessment, even if you've got the static 99, or not static 99, the HCR20, even if you've got the HCR20, and the VRAG and all these other instruments that you might be using, keep in mind the cultural competency and the cultural context of what you're looking at. Because if the only time this person has ever been violent has been with his buddies, and I'm not just the inner city, the barrio, that sort of thing. I come from an Irish family, but keep in mind where and the instances and what's led to the violence, and maybe you can help change that, but maybe you can't necessarily because it's culturally supported. So there, I've given you a little bit about cultural competency. We want to add that to all of our presentations. Importance of collateral. Records. You want the criminal records, clinical records, military records, school records. You want all the records you could possibly get your hot little hands on. Because why? People minimize people fabricate, people lie, and it's important to get the unbiased truth. I'm testing this guy. I think I talked about him earlier. He's doing life for murder, murdered a family member. Said he did it, they were both drunk, the family member said something horrible, they got in a fight, it was an accident. I go to the central file and I read the police report. One of our audience members were talking about how the police reports always make the person in front of you look like a monster and look bad, but you know, it's kind of important to put the personal side of things. And the police report talks about how the family member was found dead by a next door neighbor or something. And they went through this whole investigation of talking to all of these different people and learning that my client talked to one of the neighbors about possibly inheriting the house that this family member was in, how much money he would get if this family member died, and then a different neighbor who wasn't doing so well, how much this other neighbor would charge him to kill this family member. Other family members talked about how he and this family member that he got convicted of murdering had always had a horrible time together. Every time they got together, they were always arguing, et cetera, et cetera. And it spelled out the details of how this guy died, which was not just by fighting and falling and hitting his head, but by being stabbed 30 times. So, importance of collateral information. Did that change what I'm doing with him with my assessment? No, because my assessment is a neuropsych assessment. But if I was doing a different type of assessment, like a violence prediction assessment, those details might be a little bit more important to me now. Collateral information, friends and family. Talk to therapists and doctors. Talk to the parole and probation officers. Talk to as many people as you can to get a better sense of who this person is. You would do this for pretty much everything, but I think it's particularly crucial for any type of risk assessment. Now, there are different populations that are at more risk than others. The mentally ill individuals are sometimes at a higher risk for violence. Now, that's according to a couple of the studies that are out there that I was reading. In general, it is a myth. Mentally ill people are out there, you know, getting in fights and being more violent. But sometimes mentally ill individuals can be at greater risk for violence. Personality disorder, especially the antisocial personality disorder or people who have psychopathy. And of course, psychopaths are 4 times more likely to have a violent reoffense. And as we talked about over here, one of the static risk factors is traumatic brain injury, increases likelihood for impulsivity and lower frustration tolerance. Pretty much any type of head injury is going to slow your processing, especially right after a head injury, which will increase frustration tolerance, which may increase a person's likelihood to act on impulse. That's why we should all be wearing helmets.